that you see around, and then these osteoclastic giant cells. The really neoplastic cells, real neoplastic cells are these mononuclear cells. These are neoplastic cells. These giant cells is the osteoclast giant cell. These are reactive. And as a matter of fact, when you look at it, these neoplastic cells actually have a lot of rank L. And remember what rank L does. Rank L activates, attach to the rank and activate osteoclasts. So it's really these osteoclasts that you always see it in giant cell tumor, but they are kind of activated or reactive osteoclasts to these individual mononuclear cells, which is a really neoplastic cells. The last, on this picture, you look at this picture, you can see very, very thick bone, abnormally thick trabecle, and there are some cells here. When you look at these cells, they're not supposed to be there. They're abnormal, they're promorphic. This is the metastasis. The fact that you see this is associated with the increased production of bone means osteoblastic production. This is a prostate. So this is an example of prostate. Remember, it's the prostate produce bone, activate osteoblast, and then you're gonna have a osteoblastic metastasis. So you can see all this thickened bone, but it's not stable. Very fast about this case. There's going to be on your CD, the third case. Remember, this is a arthritis, it's a differential line. On your CD, there is a chart that actually is a different type of the, synovial fluid. Normal, non-inflammatory, inflammatory, septic. You need to memorize those numbers for exam, small group exam on Tuesday, okay? So you're gonna get a case that give you a synovial fluid and we will tell you, okay, look at, this is a number of WBC, this is a percentage, this is a color, and based on that, we expect you come up with the diagnosis. So you need to memorize that, okay? Now, this is actually contrasting rheumatoid arthritis versus DJD, osteoarthritis. You all know rheumatoid arthritis. This is an autoimmune disease, type 4 hypersensitivity. It's T cell actually, CD4 T cell start all this. This really is a synovitis. So systemic disease. When you see these CD4 T cells that bring the macrophages, that bring the B cells producing, become plasma cell producing antibody, and the antibody is very important, is rheumatoid factor. Rheumatoid factor is an IgM against FSC portion of IgG. Remember how this involved the small joint of the hand and feet. They are symmetric. They never involve DIP. That's one way to separate it from DJD. DJD actually is a large, kind of hip, knee. It's asymmetric, but the DJD, the genetic joint disease or osteoarthritis also involve, DIP, distal interphalangeal. So the main things about this, when you contrast these, rheumatoid arthritis, as I said, systemic, is inflammatory. This disease really is the primary disease of synovium. It's a synovitis. The reason cartilage damage and destroy and you're gonna have a fusion is secondary. When those inflammatory cells in synovium producing lots of cytokine, neutrophil come over there, they release enzyme that damage cartilage. In contrast, when you talk about osteoarthritis, it's primary disease of cartilage due to the mechanical pressure, due to the biochemical alteration. So when you contrast, rheumatoid arthritis is a systemic disease, it's autoimmune, inflammatory disease of synovium. Osteoarthritis or DJD is a primary disease of cartilage. It's really here and here. I want you to remember the numbers here, so you see how we contrast. This is actually for the patient. You can see this patient have a inflammatory synovial fluid with the 3,000 cells, about 50% of the neutrophil. And when you look at it, actually, HLA-DR positive, that goes with rheumatoid arthritis, rheumatic factor. By the way, rheumatic factor is not specific. You can see it with you can see it in normal people, older, with infection, TB. So it's not specific, and you don't see it all the time. Now, another thing about this case is important. When we talk about rheumatoid arthritis, remember about rheumatic nodule. We're going to look at the picture of that. Rheumatic nodule usually seen in the extensor surface, and usually seen when the disease is relapsing, flare up. So usually situation that Is involvement of lots of joint, and its rheumatic factor is very high, so usually seen as a severe disease or relapse of disease. Now, this is a DJD. Remember, DJD is due to the mechanical pressure or biochemical alteration of the joint, alteration of cartilage. Is a primary cartilage disease. Remember, it's usually, you can see its system is usually associated with age. So wear and tear. Now, sometimes you can see it in 5% in young patient. When you see it in young patient, it's secondary. Probably there are some problem. Maybe obesity. Maybe the patient actually playing football and there's a lot of trauma on the knee, and then you're gonna see DJD over there. So when it is actually secondary, most of the time are localized and there are some trauma. Diabetes is another example of secondary. Hemochromatosis is another example of the, you can see DJD with hemochromatosis, okay? So when it is secondary, think about some kind of, trauma, some kind of history. But the primary usually age. With the age, there's gonna be wear and tear of that cartilage. And if the patient is obese, it's the worst. And I want you to compare these numbers with that. These are DJD, synovial fluid, not much of cell, not much of neutrophil. Remember, viscosity and normal viscosity usually is high. When actually normal synovial fluid, you touch it, you can separate it with your finger, there is a stream. So normal synovial fluid is very hyperviscous. When there is inflammation, because inflammation damage or destroy those protoglycan, with the hyaluronic acid, you're gonna become like a water. There is no viscosity. So viscosity is here normal. Now, rheumatoid arthritis, small, metaphalangeal, PIP, DIP is not involved. Usually symmetric polyarthritis, polyarticular. In the long run, with that inflammation and damage, you're going to see fusion, you're going to see deformity. So, and this is what you see, because this is inflammatory, it's systemic inflammatory disease. When you look at the synovial tissue, you see how erythematous, how inflamed it is, and actually you can see some fibrin. Remember first unit, we talked about the local feature of the acute inflammation, what you see, erythema, tenderness, pain, these are all actually, sometimes the joint is very tender, it's warm, erythematous. That's what you see because there is inflammation of synovium. What you see here, very important buzzword for these rheumatoid arthritis, is this structure. These structures are hyperplastic synovial tissue. So synovial tissue should be aligned, kind of flat. You see here, this is actually joint space. You see this synovial tissue, how hyperplastic, actually kind of papillary protruded inside. And inside this synovial tissue, lots of inflammatory cells. Remember T cells, plasma cells. Actually, this is an aggregate of T cells. We call this pannus. Pannus is one of the hallmark of the rheumatoid arthritis. Actually, it's one of the causes of the damage to the cartilage. These inflammatory cells and pannus. So, if somebody asks, what is the pannus? Is hyperplastic synovium that is raised kind of inside the joint and contain all these inflammatory cells. What type of inflammatory cells? Mainly are lymphocytes, T cells and plasma cells. If it's a relapse or acute, attack of disease, you can see neutrophil too. What type of hypersensitivity is rheumatoid arthritis? It's the T cell, type 4. Now, look at what's happened. After cartilage gone, the joint become narrowed. You can see all these fusion, all these uncloses, and you can see all these deformities. Some of these deformities because of when you have a joint is fused, those tendons, you don't use those tendons. So they contract, they become shortened. That's the reason some of these deformities because of the effect on the tendon. Sometimes inflammation can involve tendon too. So they call it swan neck, they call it ulnar deviation. So these are all different deformity you can see. Rheumatic nodule. If I ask you what is rheumatic nodule, in reality it's a granuloma. Because at the center you can see fibrinoid necrosis, at the periphery you have a collection of histiocyte, epithelial histiocyte, and some lymphocyte. So this is in reality, it's a granuloma. delayed type hypersensitivity. Remember, granuloma. Systemic disease, same T cells can affect soft tissue. Rheumatoid arthritis, you can have involvement of lung, involvement of the heart. It's not just the joint. PJD, primary disease of cartilage due to the mechanical pressure. You can see this is actually distal femur, and you here see this is a cartilage, shiny, nice. You can see there was a loss of cartilage here, loss of cartilage here. This is a pathology, open it, again, loss of cartilage here. So when you have a loss of cartilage, actually what's happened is those nerve end, which is in the subchondral bone, they go over each other and then there's produced pain. Cartilage, usually, as long as you have cartilage, it's not going to be much pain. When they're exposed, those subchondral bone, there's going to be a pain. Now, one of the characteristics of these DJD, osteoarthritis, is this structure. We call this osteophyte. What is osteophyte? Is this mushroom outgrowth of the bone at the edge of the involved joint. So it's some kind of, I guess, reactive response to the pressure and loss of cartilage. So mushrooming, growing of the bone up there. This bone usually have some kind of fibrocartilaginous cap that later actually become mineralized, become bone. Osteophyte is very, very important because they love to ask you about that. And so every time they shoot a joint and at the side of the joint you see this bony outgrowth, think about the osteoarthritis. Again, vertebra is another area that you get osteoarthritis. This is a bone due to the degenerative joint disease. Only appreciate surface. There was some left, most of it is gone. And this is in the stage. The whole cartilage gone. This is a bone actually over bone. So they call this hibernation. Shiny, smooth, sclerotic bone. No cartilage. It can be very, very painful because these are all in nerve terminal and bone friction over bone is going to produce lots of pain. What is this? See this outgrowth here? Osteophyte. So, a little bit about crystal-induced arthritis, the gout. Remember, needle-shaped crystal, they are negative birefringent. Acute attack of gout, this is a very commonplace, first metatarsophalangeal. Remember, the people that have a gout, they usually associate with hyperuricemia. So the joint is not the only area involved. They can involve other organs, especially kidney. In gout, you can get acute renal failure. You can get a uric acid stone in the kidney, and sometimes there can be chronic renal failure and renal insufficiency. You can die from that. So this is the least concern, the joint. Now, we don't see this anymore. This is a very, somebody that never actually got the treatment. So usually is confined to the joint, but you see not only wall of the joint, those crystals, and you can see it actually is open up here, but sometimes actually, if you don't treat this hyperuricemia, the uric acid can deposit in the soft tissue around the joint too. And I want you to appreciate here, we call these tophi or gouty tophi. So you can see this is in soft tissue. Imagine a crystal of foreign body actually deposit in the soft tissue. The same way they can deposit in the kidney. I already talked about that. So when you see them in soft tissue, these are foreign bodies. These are composed of those, crystal. The fact we don't see those needle-shaped crystal because when it goes through the process and alcohol, they dissolve. But you can see that actually it's foreign material. And every time you have a foreign material in the tissue, you're going to have a granulomatous reaction. We call it foreign body granuloma. So you can see these are histiocytes, they are giant cell. So this is a foreign body granuloma. Done with this case, the last case is a case of the acute osteomyelitis. This is a real case, it was missed. So originally this patient came, they thought it was an accident, they thought it was a fracture. In reality, it was not a fracture. Patient had otitis media, and most of the time the osteomyelitis actually, especially in children, comes from another source of infection. This patient was an infection of EU, and then that infection can go and stuck in the bone and produce osteomyelitis. Remember, in this age group, most common location is a metaphysis, have all these vascular loop. Based on age, the location is a little bit different. If you think about the neonate, in neonate actually, the vessels in the metaphysis enter to the epiphysis, so they penetrate epiphysis. So in neonate, when you have osteomyelitis, you're going to have an involvement